Welcome back to the channel, everybody. Today's video deals with a patient that has undergone PK and an pupillary IOL explantation and was left aphakic. He had bullous keratoplasty, long-standing from a traumatic cataract, and that kind of pupillary IOL that you sometimes see in Eastern Europe or Russia, the type of IOL that is implanted in the pupillary space and has some haptics that lie anterior to the iris and posterior to the iris. So he also had some vitreous coming out from the back and through the defects in the capsular bag, and also, as is often the case in trauma, there is a lot of posterior synechia that we need to lyse and sometimes even cut with intraocular scissors, simply because the adherences are too strong, and you wouldn't want to rip the bag, because in this case we want to use the sulcus as a means of 3-piece IOL implantation. So we're looking for a place to create our 2.4 millimeter incision, and we inadvertently cut one of the sutures from the PK. And this is safe because this surgery has been done at least 3 months ago, I believe, and one loose suture or one cut suture will not make a difference. So we can always replace it if we feel the need to. Then the IOL implantation is done under viscoelastic, with especially being mindful to inject viscoelastic behind the iris and anterior to the capsule so as to create the sulcus. And then with intraocular forceps, we simply place the haptic inside the sulcus, and then we rotate it. We rotate the whole IOL, and then we inject some more triamcinolone simply because we want to check for vitreous, and we take out the suture. Thanks for watching.